Hey guys, welcome to my channel. My name is Memo Cano and this is MC Teaches. This is a little bit different. I'm used to making chest videos, but today I decided to study a little bit of medicine. And so the topic of today that I want to touch on is hypernatremia. So hypernatremia, it's always electrolyte abnormalities or irregularities or they've always been a little difficult for me, so I thought, why not try to teach it so that I can learn it as best as I can. And so today it's going to be very simple, very basic. I'm going to talk about the clinical symptoms, the signs. Then I'd like to talk about the diagnostic criteria or how to diagnose hypernatremia, and then of course the treatment. And so I'm going to go ahead and start with the clinical findings. As you can see, there's 5 of them here, and I'm going to go ahead and show my thought process in order to, 1, better learn the topic, and 2, if anyone finds any discrepancies in my thought process, they can go ahead in the comments, talk about or correct me if I'm wrong, right? So we're going to start off with thirst. And so thirst, and these are clinical findings. I found this material in the Step 2 CK first aid book. That's just what I have on hand. So thirst with hypernatremia, that seems pretty logical to me. You're going to have a lot of solute in the solution. Your osmolarity is going to be increased. You're going to have increased osmolarity due to the elevated solute from the hypernatremia. Your body is going to want to balance that. Your osmoreceptors, maybe in your hypothalamus or something like that, they're gonna be going off, and they're going to increase your thirst. Your body is going to upregulate your thirst drive, and so you're going to get so that you drink water, right? So thirst makes sense. Altered mental status. These next 4 are neurological, I believe. I don't know, like the weakness is a little vague. I know electrosodium is used a lot in muscular contraction, as well as calcium. Maybe you're going to get weakness due to that. I know if you have like a seizure due to the hypernatremia, which is possible, you're going to have weakness due to your muscles continuously contracting and clenching, and depending on the type of seizure, right, it's going to vary in severity. Focal neurological deficit and altered mental status. You see, I don't really, besides the fact that every nerve in your body uses a sodium potassium, various sodium channel pumps. Maybe there's misfiring of certain areas, and now I'm thinking, right? Maybe there's misfiring of certain areas, and you're gonna have those symptoms like focal neurological deficit, altered mental status, and then I know correcting hypernatremia has to be done slowly due to the pontine demyelination syndrome. So that's something you want to keep in mind when you're treating hypernatremia. Excuse me. So that's it with the clinical signs. Next, I'm going to go into diagnostic criteria, and after that, I'd like to go into the treatment options and treatment. For the diagnosis here, we have a diagnostic algorithm given to me by the USMLE Step 2 CK First Aid book, and I'm going to go through with you guys. I haven't really thought this through, so I will be thinking about it as I teach it. So we have hypernatremia, and so the diagnosis is based on urine osmolality plus urine sodium. So you're measuring the osmolality of the urine and the urine sodium, and part of the diagnosis is there's a water deprivation test, and as I'm thinking about it now, there's some bases that you need to understand about nephrogenic diabetes insipidus and central diabetes insipidus, because those are some of the reasons why you would have hypernatremia. But I'll get to that shortly. So you have hypernatremia, and you have urine with high osmolarity and urine with low osmolarity. And high osmolarity is defined as greater than 600 microosmoles per kilogram, and low urine osmolarity is defined as less than 300 microosmoles per kilogram, right? So I'd like to go through if you have a high urine osmolarity. So the two options with high urine osmolarity, according to this book, is extrarenal losses and sodium gain. So I don't really understand this. So extrarenal losses of what? Sodium? Why would you have extrarenal losses of sodium and have hypernatremia? I'm not sure. But anyway, so extrarenal losses, you can have like vomiting, for example, an extrarenal loss. So vomiting, you're getting rid of HCl, chloride, and sodium chloride. Okay, diarrhea is another one. A nasogastric tube, suctioning, and insensible losses, which I have no idea what that means. And if you have sodium gain, you can have sodium gain due to hypertonic saline. But yeah, so there's a lot of holes in that one. When you have low urine osmolarity, so less than 300 microosmoles per kilogram, I'm just gonna go down the line because my thoughts here are jumbled and I'm not really understanding it very well. But you're gonna have high urine osms. If you have a high urine osm with decompression following water restriction, you have central diabetes insipidus. And what is central diabetes insipidus? So nephrogenic diabetes insipidus is lack of response to ADH in the kidneys. So I would assume that central diabetes insipidus is lack of production of ADH in the hypothalamus. Yeah, posterior hypothalamus, I think, along with oxytocin, maybe. ADH and yeah. So ADH, central diabetes insipidus. You can have no rise in urine osms. So that's central diabetes insipidus. If you have no rise in urine osms with decompression following water restriction, then it's nephrogenic diabetes insipidus. And so that's the diagnostic criteria. Like I said, it's not the best thought process here. I have to go look through it a little. Maybe, well, let's do it now. So increase urine osms. So increased urine osmolarity is decreased water, decreased fluid coming out and more solute in the urine. I believe. Alright guys, so back to the diagnosis. So here, with increased urine osmosis with decompression following water restrictions, making the diagnosis central diabetes insipidus, and the no rise in urine microosmosis with decompression following water restrictions being nephrogenic DI. Okay, so when you have nephrogenic DI, you could be producing all the ADH in the world, all the antidiuretic hormone, which causes you to retain fluids. I think it's by V2 or aquaporins, right? Maybe. So, nephrogenic DI. Right, you have all the ADH, but your kidneys have no receptors for the ADH. So you can deprive yourself of water and you could be producing all the ADH in the world, but it's not going to have an effect renally in the kidneys because you don't have that receptor. In central diabetes insipidus, you have an appropriate response. Right? With central diabetes insipidus, you're going to have increased urine osmosis, so you're going to be concentrating more your urine with water deprivation because you're going to be producing a little bit of ADH. That's what I'm thinking it is. I may be wrong, but so that's a little bit of explanation about this. The extrarenal losses in high microosmoles per kg. Maybe it's extrarenal losses of water. When you're vomiting, you're getting rid of water, so you're going to have high microosmoles. So you're going to be concentrating your urine. That makes sense. Diarrhea as well. You're getting rid of water, so you're going to be concentrating your urine. NG2 as well. You're suctioning fluids. And insensible losses. I'm not sure what that means, but I'm guessing dehydration. Other things, you're going to have hypernatremia, which it makes sense, right? Dehydration can be a cause of hypernatremia. Anyway, so this is the diagnosis portion. I'm not saying it's completely comprehensive. It's just what I'm getting off of the book, and I'm doing this on the fly. I'm not preparing. I didn't prepare for this, but it's also good because I'm training myself to understand it on the fly. I'm training myself to kind of get it and try to make logic make sense of it on the fly, which is just a one strategy to learn this material. So from diagnosis, I'd like to go into treatment. Treatment seems to be a little bit longer of a section here. So, symptoms, diagnosis, and treatment. But I misspoke. I also want to talk about the causes, right? So according to the book, the causes, there's 6 Ds, which makes it, the mnemonic makes it a little easier. The diuresis, so if you get rid of water, a lot of free water, you're going to have hypernatremia. And these are causes of hypernatremia. So dehydration, again, you don't have free water, you have the solute still within you. You can have hypernatremia due to low water volume as well. Docs, iatrogenic, there's different causes for hypernatremia due to medications. You can even hypertonic saline can cause hypernatremia. So we can definitely, as doctors, we can definitely cause hypernatremia. Diabetes insipidus, again, this is an interesting fact. Diabetes mellitus, mellitus is like miel, sweet, so you have sugar in the urine. Diabetes insipidus is you have a lot of salt. in your urine, and it's going to make it insipid. So that's an interesting fact that I learned at UTMB Galveston. I'm pretty sure one of the doctors that was teaching me then, he taught me that. And so diabetes insipidus is a cause of hypernatremia. Diarrhea, again, I think diarrhea is getting rid of free water. You're gonna have solute. It's basically dehydration again. So, and then disease, you can have renal disease that causes hypernatremia, and according to the book, sickle cell disease as well can cause hypernatremia. There are holes in my mental map about that. I don't know, I'm not quite certain how sickle cell causes hypernatremia, but according to the book it does, and I'm sure I'll get there. And if someone knows how sickle cell causes hypernatremia, comment down below. Alright guys, so for the treatment, make sure you listen to this treatment because there's certain details that can either save or kill a life in this video. So make sure you stay till the end in terms of the treatment. So to start off, you want to determine the volume status of the patient. If hypovolemic with unstable vital signs, you want to use normal saline before correcting free water deficit. So if their vital signs are off and they're low in volume status and they're unstable, just isotonic 0.9 NaCl fluids. I believe that's normal saline. So that's before correcting free water deficit. Now, if they have normal volume status, you can treat with D5W, half normal saline, or enteral fluids. So to add on to what I just said, even with stable vital signs, you want to use the isotonic saline 0.9 sodium chloride solution, which is normal saline, until euvolemic. What does euvolemic mean? Normal volume status, not hypotonic, not hypertonic, not hypervolemic or neither hypovolemic. It's euvolemic is at a normal state. So you want to use normal saline for those patients, even if they have stable vital signs. So after you determine volume status and you've assessed the patient appropriately and treated the patient if he's unstable with normal saline or half normal saline. Normal saline, by the way. What is half normal saline for again? If the patient is normal status and asymptomatic, you give normal saline, half normal saline, by the way. If the patient is unstable and doesn't have normal volume status, you want to go with isotonic normal saline. Once you've assessed the volume status of the patient, the next step is to determine the free water deficit. And how do you determine the free water deficit? So water deficit is equal to total body water times the serum sodium divided by 140 minus 1. So that's the formula that you use to determine the water deficit. The total body water is plus or minus 60% of the total body weight. And I misspelled replace. So you replace that water deficit with D5W, half normal saline, or enteral water. That's the next step. Okay guys, remember at the beginning of the video, or at some point at the beginning of the treatment, at least the treatment section of the video, I said it was very important for you all to stay till the end of the treatment section because it is a life and death matter. Well, we've gotten to this point. So the next step, after determining volume status, after determining total free water deficit, the next step is to determine rate of replacement. So correction of chronic hypernatremia, and chronic hypernatremia, according to this book, is defined as greater than 48 hours of hypernatremia, should be done gradually. As you can see, I've underlined it 3 times to emphasize the importance of this. So you gradually, over 48 to 72 hours, with less than or equal to 0.5 milliequivalents per liter per hour. And that is to prevent neurological damage due to cerebral edema. Think about it. We have hypernatremia. Your blood is full of salt, right? So I learned at UTMB Galveston that water follows salt. Water follows the sodium, right? Therefore, this is my thinking. Correct me if I'm wrong, please. So you have hypernatremia. You're loading. Your cells are uptaking some of this sodium, right? So your cells start to get filled with salt. You push more water. If you push more water, those cells are gonna uptake water, and so your brain's gonna swell. Thus cerebral edema. And if you do it too quickly, greater than, and this is an experiment done by someone who obviously probably made mistakes, probably killed a couple of patients to get this number. I mean, maybe didn't kill them on purpose, but maybe some patients died getting this number. So this is a very important number. Less than or equal to 0.5 milliequivalents per liter per hour. If you go above that, you run the risk of killing the patient due to cerebral edema. All right, so finally, to conclude the treatment section, euvolemic and hypervolemic hypernatremia are extremely rare, but they do happen. So the treatment for that is usually a combination of diuretics and D5W to remove excess sodium. And so this is the hypernatremia section, and if anyone chooses to go through this video and correct me, I would appreciate it. I want to know the truth, especially with a topic like this that can mean life and death. Please remember that it's less than or equal to 0.5 milliequivalents per liter per hour. That is probably the most important part of this lecture. I appreciate y'all watching. Like and subscribe if you enjoyed or if you learned something, and I do plan on posting more. So again, welcome to this channel, and thank you. Peace.